So, hello everyone, and welcome again to JOSPT Asks, the weekly chat where you, the audience, get your questions answered. I'm Clare Ardern, the Editor-in-Chief of JOSPT, and it's great to be chatting with you again this week. Thank you again for taking the time to join us. Thank you also for posting some terrific questions on Slido and for all of the feedback that we're getting and the support for JOSPT Asks. Today on JOSPT Asks, it's a pleasure to welcome Professor Jeremy Lewis from the University of Hertfordshire and the National Health Service in the UK. Jeremy helps to teach the next generation of physios at the University of Hertfordshire, and I'm sure that many in our community have seen Jeremy teach workshops. You might have seen him present at conferences. You've probably read some of his excellent research, and I'm sure that many of you will know how passionate Jeremy is about evidence-based practice in managing shoulder problems. So it's a pleasure to have Jeremy on JOSPT Asks today to help us get confident at effectively managing shoulder problems. Welcome to JOSPT Asks, Jeremy.
Thank you very much, Claire. It's a great honour for me to be here. So thank you very much for the invitation.
Thanks for joining us. I would like to start with a question that we usually have at the end of our sessions, but I think it's really pertinent to talk about it up front today, and particularly given your role as a physiotherapist in the community hospital through the National Health Service. And that is, how has your practice changed during the coronavirus pandemic? Has there been some tele-rehab going on? What have you been doing that might be different from your practice from perhaps January this year?
Great question to start with, thank you. So I guess for all of us, we've all had to adapt to a new normal in the last few months, and probably most of us have recognised that the old normal wasn't working, and it's maybe a time even to think about what the new normal could look like, and maybe we can in some ways try and formulate that. I guess my world's changed in many ways because I spend a lot of time sitting where I'm sitting, trying to put on a nice shirt, sometimes with PJ bottoms or something else. But in terms of university work, a lot of instead of one-to-ones with doctoral students or master's students, it's been through this medium, through Zoom or through MS Teams or Skype, not wanting to publicize one company more than another. And so that's been interesting to have the social relationships and listen to people's successes and failures and how they're coping with the big wide world together with their academic work. But also for patients as well, it's really been quite enlightening. And in some cases, I'm not doing non-stop telehealth. I'm probably on average maybe doing, I would say, 5 people with shoulder problems a day. I guess that would be on average. A lot of it's sort of just pro bono stuff and just helping other people out. But it's been pretty manageable. It's demonstrated to me that that you don't have to use a lot of hands-on. We can be very adaptive. We can adapt and use other skills to empower our patients. The times it's been really difficult for me is that my practice in the UK, physiotherapists in the United Kingdom, physical therapists, if they've been trained, can prescribe medicines and also perform injections. And part of my practice is ultrasound guided injections. And of course, there is an element of risk with the procedure, but it's probably the most evidence-based treatment we have in the first interesting in the last 3 weeks is nearly just to have a frozen shoulder and are in the painful stage, and it's very hard to help manage them via telehealth. But the other problems, such as a rotator cuff problem, it's actually been quite easy, and it's really been very much the patient's response. I'm very much sort of, I guess, how the patient has responded to this form of communication.
Now, we just lost your internet for about a 10-second block there, but I think the point was, it was when you were talking about injections and I think not being able to deliver injections via telehealth, but that telehealth also gives you a lot of other options and ways of engaging patients who have other types of shoulder problems. Have I got that right?
Yeah, so the only real injections I ever do are for the first stage of frozen shoulders, where there is evidence to support that, as long as the patient understands the risks and the harms and the benefits. And it's sometimes very effective in reducing pain and starting to restore movement. But that's the one thing I've noticed, that I would like to be able to discuss that with patients, to present it as an alternative in terms of shared decision making. And if patients are keen to go ahead, once they understand the risks and benefits, then that's something I can't offer, because it can sometimes be quite dramatic in terms of pain reduction.
So let's then talk about what you see as being the key components of a good approach to managing shoulder pain.
Okay. I guess it's a good question, and it should be a simple one to answer, but I can see myself already meandering in my head. So I guess the important thing is the initial interaction with the patient. I've really tried very hard to make that first meeting as appropriate and as special as possible for patients. And I guess there'll be no difference in managing someone with a shoulder problem, back problem, or even someone with diabetes. I guess my approach would be very, very much the same. It would be to make sure that I find out how the patient wants to be introduced, and the patient wants to be addressed. I make it really important to set the scene, to tell the patient that we've got half an hour or an hour, and during that time I want to understand in their own words how their shoulder problem has been affecting them. I want them to know that once we finish the conversation, that with their permission, I'll do an assessment, and once I finish the assessment, sit down and talk about what I found, present the different management options to them, and together we can decide how best to move forward. So I want the patient to be very much, I want the patient to understand at the beginning that that they're going to be a key partner in any decision about their health. I'd always try and start the session with a question that is not related to the reason why they've come to see me. I'm sure we've all been to doctors and dentists and other health professionals where you just sort of feel, someone's looking down and writing things and not really addressing you as a person. And I would always try and ask a question to show the patient that I'm interested in them as a person. Nothing complicated, political. Something as simple, did you find the car park easy? Did you get caught in the rain? It's always raining in London. So something to show the patient that I'm interested in them. Setting the scene, as I said, is really important, because patients don't know how long we've got together. They don't know what will happen within the session. When I then would invite the patient to tell their story, usually, most people fit within the research. They speak for 60, 90 seconds, whatever they want to say. I wouldn't ever say, tell me about your shoulder problem, but I'd just say, tell me your story, because it allows the patient to talk about what is important to them. And then after that, just then become a forensic detective, a crime scene investigator, trying to understand them better. And that would be whether it's an Olympic athlete or whether it's a garden variety human like myself, or a more elderly person in society. I would follow the same approach with everybody in terms of the subjective. And then a very simple physical examination. I don't spend much time on the physical examination. Most of my time is, I guess, now spent on the interview stage with patients.
So lots of talking, and we're going to get to the some issues around assessment, and then about planning the next part of the program in a few questions time. But I wanted to come back to this idea of the terminology that we use, and you use the term rotator cuff related shoulder pain in your articles. Where does that pain come from, and does it really matter what is causing the pain?
Right. Whoa. Okay, I need some vodka for this one. I've been struck. So in terms of assessing people with and trying to help care for people with shoulder symptoms, I guess we've been through a big evolution in the last few decades where when I first started my career, it was all about nociception. It was all about identifying the structure. It was potentially even being jealous of people who could image and operate to improve the structural integrity of the musculoskeletal system. And what's been really fascinating to observe as a participant, but also sometimes as an observer to the process, looking at other people's research, as well as contributing a little bit, has been how the focus has been very much moved from we can identify the structure that's causing the symptoms to one of actually, if we're really honest, we in most cases, especially in non-traumatic presentations, haven't got a clue. We've got all these great clinical tests, we've got all this, we're so lucky, we're the first humans to see inside the body in people who are alive. I think we had x-rays. I think the first x-rays were 1895, and in the 1970s we had the introduction of CTs and MRIs, and from the 90s an explosion in the use of ultrasound in clinical practice, all with a belief that if we could see something that was different, we could then inform ourselves and the person with the symptoms what's causing the problem. But then, of course, we have all this research that comes along and says, well, actually, almost the same amount of pathology and the same type of pathology, if you want to even call it that, is present in people without symptoms. So maybe what we're actually looking at is just normal age-related changes, wrinkles on the inside, grey hair on the inside. Wrinkles don't hurt until you see them. Grey hair doesn't hurt until you see it. But so I wonder if a lot of the things that we're seeing are just normal age-related changes. And so my first part of my career was all about impingement, and then I suggested maybe we could use the term subacromial pain syndrome. And then more recently, I was thinking, well, let's call this condition rotator cuff-related shoulder pain. And a lot of people were critical of that term when I suggested it, and possibly rightly so. It was an interesting debate. But in my head, rotator cuff-related shoulder pain is only ever a hypothesis. You can never confirm it 100%. It would be possibly something I might write in my clinical notes if I can't identify any reason for referred pain from the neck, the thoracic reason from visceral tissue, even though I know that those tests are pretty limited anyway. The patient would have had most likely a history of change in load, or maybe substantial lifestyle changes, that there'll be more pain on elevation or external rotation of the arm. And for me, I don't know the structure. In my head, I'm thinking it could be muscle, it could be tendon, it could be bone interface, it could be bursal tissue, it could be the very complicated pain neuroscience. It doesn't even have to be local in the shoulder, but it has to have those features. And then I would make a clinical decision that it's rotator cuff-related shoulder pain. And I want to move away from terms such as impingement, and I've been writing about this for a long time. One, because impingement probably doesn't exist. It was a great theory presented by Neer in 1972, and millions of people have had their acromions removed around the world, probably unnecessarily, but because of the belief that it was the acromion. And if you tell a patient you've got impingement, if you told me that, and I was also told I need to have an operation to remove the offending bit of bone, I'm never going to engage with anything else, because in my head, I'm perceiving this piece of bone that's causing the impingement that needs to be removed. And what could anybody else do except possibly help me after surgery? So the idea behind it was to use a term that involves muscle, and you could ask a patient, what do you know about muscle? And a patient might say, well, I know that some people do exercises to improve the quality of muscle, and you can compliment the patient on being so knowledgeable, and you could tell them that's exactly what you need. In most cases, that's the best treatment for this condition. It's to find a safe entry point for you and to build up the strength, the endurance of your muscle tendon, and all the other wonderful added benefits of exercise is one way of tackling this problem. And the idea was to move away from a definitive pathology structural diagnosis.
Great. So then what is the value of special tests in diagnosing shoulder pathology?
Am I allowed to be honest?
Please, we like honesty. We encourage honesty.
Well, I spent a lot of time learning at least 60 special tests and understanding the sensitivity and specificity of them and the positive and negative predictive values of them. And I could quote that even after 2 vodkas or 3. But I guess what I've learned in our research and what I've read from other people who've done really important contributions to this is and we've just done a viewpoint. Paul led on the viewpoint, and he's got a webinar, a discussion like this coming up for Journal of Orthopaedic Sports Physical Therapy in a few weeks' time, which would be fantastic to listen to. And if you're out there, Paul, great. And the paper that Paul led on basically, I think, encapsulates all my feelings about special tests. They've passed their sell-by date. We again need to understand that we used to believe that we had this ability to identify the structure that was causing the symptoms, and that's the whole value of special tests. They were designed to identify whether it was the labrum or the supraspinatus tendon or whatever you want. And the problem is we should only really consider them as pain provocation tests. And the reason for that is the gold standard that the tests are compared to are observations such as ultrasound, MRI, or direct observation during an arthroscope, for example. And the value of the tests would work if the changes we saw were only changes that happened in people with symptoms. The problem is so many people walking around with the same changes, the same grey hair wrinkles on the inside. And so the gold standard reference tests that we have, in my opinion, are not even precious metals. They are just simply pain provocation. And so to do a test such as the full can test or the empty can test, and say to the patient, it's your supraspinatus, and yes, I can confirm that on the ultrasound, and it's torn and you need surgery, is very dangerous, because it's not really, in most cases, not able to identify the actual structural cause of the patient's symptoms. If the patient lifts up their arm and says it's sore, in my opinion, there's no added value to a special test, because they're just pain provocation. And that's whether it's a young teenager, an Olympic athlete, or an older person such as myself. I do not see the value in the tests, with the exception of some of the tests for instability. But if we're talking about rotator cuff, I think Paul's paper encapsulates it beautifully, that there's really no added value for the tests.
And do you want to elaborate on the couple for instability?
Yeah, so things like load and shift, anterior draw tests, posterior instability tests. There is some more street credibility with some of the instability tests, but again, I'm probably one of the laziest people you'll ever meet, and I don't do a lot of physical examination. I'm more interested in what causes the patient's symptoms, and am I able to do anything to alleviate the symptoms with the process I use clinically, and that for me helps inform my clinical reasoning better. So if someone might have a history of instability, they've had a dislocation and they're struggling to do a push-up, I'd be more interested in experimenting with, can I change the symptoms when they do that to inform my clinical reasoning more than actually relying on some of the tests? Can I reduce their symptoms more than provoke their symptoms?
Now, you've alluded to your approach, this symptom modification approach, Jeremy. What does that entail? Can you share a little bit more about how you would approach symptom modification in the clinic?
Yeah, okay. I guess I have to put a disclaimer underneath. For a lot of people, this is the devil's work, and so I have to be very careful here. There'll probably be someone who end up throwing paint through my window in a second. So in 2009, when I started to write about, are special tests special, and can we really call this condition impingement, I got a lot of flack from surgeons and from physios in terms of, how dare you write about this? And then what's been really, I guess, encouraging over the last few years is the number of studies that have come out that maybe suggest that the surgery isn't addressing the shape of the acromion, etc. And I took a plunge in 2009 and writing about how I'd been assessing the shoulder for many years, not really being brave enough to publish it, but took the chance. I was thinking it would be the end of my career. And so over time, I developed this thing that I call the shoulder symptom modification procedure. Many other physios have different names for it, such as improvement tests or treatment classification or treatment direction testing. And it's a really, really small part of my assessment. The 2 or 3 minutes that I would have in the past spent on special tests, on orthopaedic tests, is where I now use these symptom modification procedures. And it flows through a process, just so that an old person like me can remember it, but the order is not important. And it's simply trying, once the patient has identified something that causes pain, such as putting their hand behind their back, throwing, washing their hair, whatever it might be, just to go through a 2-3 minute system of tests, of techniques that try, it's all about the patient. This part of the assessment's all about the patient, for the patient to say, it's better, same, or worse. Now, very often I'll go through the process and the patient says, well, that was a waste of time. But sometimes patients will say, actually, my symptoms are a lot less, or I don't have symptoms. And so for me, of my 100-stage rehabilitation program, stage 1, for the patients who say, this has helped me, so for example, it might be doing external rotation as they lift their arm. And for the patient who says, that helps me, I will get them to do that movement repeatedly. I'll get them to close their eyes and pretend that they're in the situation where they're lifting their arm. So they're doing motor imagery in terms of, I can actually do that movement, picking up something, putting it in the shelf with less pain, so that they have maybe more confidence to do it. A lot of people have criticized the approach and said, if you tell a person that you're doing something to reduce their symptoms and you can't, they will become a shivering mess of psychologically damaged blob. Now, the way I would address that is, before you do orthopedic tests, you don't tell patients, I'm about to do some tests that are going to hurt you. You simply say to the patient, I'm going to do a series of tests, please let me know your response. And that's exactly what I would say for these. So a patient wouldn't have a clue what the difference is between an orthopedic test or an improvement test or a modification test. And if it doesn't change, it doesn't change. But if it does change, I will then immediately put it into the movement that the patient has found as provocative. I can't tell you why they work. I'd love to. It could be mechanical reasons. It could be neuromodulation through touch, because most of them involve touch. It could be a massive placebo, or it could be messing with the brain. It could be you know, here's a person who's, you know, for example, because the person has to think about something else while they're moving their shoulder, and it's not complicated, but it could be complicated for that person, such as squeezing a ball and lifting, or putting some rubber bands around the fingers and opening them when they lift. If the patient has to think about something else, then they might not be able to generate the same amount of thought process onto what was painful. And things like stepping forward, stepping onto a step, there are so many different ways to mess with the brain in a legal, positive way, that if it gets the patient to move, you know, great, because everybody is going to say movement and exercise is good. And if we can get someone to move with less pain, fantastic. If it doesn't work, it doesn't work. But I would never tell the patient, I'm looking for ways to decrease your symptoms. And if the patient says, why has that made me feel better? I would never give a mechanical explanation. I would never say, it's because your shoulder blade's now in the right position, or it's because your muscles are firing better. What I would say is that we know exercise is one of the most profound ways to reduce pain in the shoulder. It's one of the best medicines on the whole planet for many different situations. And we found an exercise that at this point in time helps you. Let's use it as the first stage of our rehab, but we've got another 99 stages to go. So it's not the whole process.
Now, people talk about the kinetic chain in management of shoulder problems or shoulder pain. How do you see the kinetic chain fitting into this picture?
Okay, another great question. So thank you to the person who asked that. It's really clear to all of us, whether you are a grandparent throwing a tennis ball to a grandchild, or frisbee in the park, or your national baseball pitcher, or international tennis player, or javelin thrower, wherever you might be, we don't stand and throw. We put our whole body into throwing. And we know that about 50% of the energy, force available at the shoulder to serve in tennis, to pitch in baseball, is energy that's generated from the lower limbs through the trunk into the shoulder. And in fact, in throwing, the shoulder only generates about, serving in tennis, pitching in baseball, the shoulder only generates about 20% of the force. And in serving, the elbow only generates about 15% of the force of a tennis serve. So the majority comes from the lower limb and the trunk. And we know that if you've got a sore hip, sore knee, if there's a 25% reduction in energy transfer from the legs to the shoulder has to work about 35% harder. So if a patient comes in and, you know, and they say, well, nothing's changed, and you go through the history, but the patient says, yeah, my knee's been a bit sore over the last month, and they're playing tennis, but their frequency of playing tennis and the person they're playing with hasn't changed, and they're not playing outside on a wet court, so the load factor of a wet ball hasn't changed. You're trying to be as detective as you can. It may be that the sore knee and not allowing normal energy transfer might imply that the shoulder has to work a bit harder. And so when I went through physiotherapy school in Australia, we were taught in the 1820s, we were taught that good shoulder assessment was look at the shoulder, look at the neck, and move on. But that's clearly not a good model for musculoskeletal assessment. It would make so much sense to take a whole of body approach. Now, I'm not saying there's one way that people move, but there's multiple ways that people move, but we do need to make sure that there is adequate strength in the lower limbs, quads, trunk, in order to maximize shoulder, function. And I would also suggest, not only do we have to think about the kinetic chain from down up, but also from up down. So if someone's got potentially a problem neck, you know, very often we might address that with exercise or manual therapy or modalities, but actually you need a strong neck for the shoulder to function as well. And we've got a couple of research studies going on at the moment to see if that may be a correct statement. And certainly last week in the BMJ Open, Ellie Richardson led on a paper looking at the kinetic chain, EMG studies that investigate the kinetic chain's role in shoulder function. And anyone who's interested in that, I would recommend you download it. It's open access. Just look at Richardson, BMJ, SEM, Sports Exercise Medicine Open, and there'll be more information in that paper.
Now, Jeremy, you mentioned before exercise, and exercise really being a cornerstone to management of loads of different health problems, but particularly a cornerstone of managing musculoskeletal pain and musculoskeletal problems. Let's talk now about how you go about designing an exercise program for someone who's got rotator cuff related shoulder pain. What are your guiding principles to putting that program together?
Okay, thank you. So I guess it can't just be exercise. And Peter O'Sullivan and I wrote a paper, an editorial in the British Journal of Sports Medicine, and a little while ago in the Journal of Orthopaedic Sports Physical Therapy. Chad, Pete, Tammy Hoffman, and myself put together a paper looking at entitled Too Much Medicine and Musculoskeletal Practice. And I guess the themes of those papers very much encapsulate my philosophy of managing a musculoskeletal problem. And I don't see persistent musculoskeletal problems any different than maybe other persistent health problems. So if someone was to come in with diabetes, you would gently explain, try and understand the patient's level of health literacy, try and get them to understand the problem, understand what different members of the health community can do to support that problem, but to make sure the patient understands that it's really going to have to be a lot of self-management with a lot of support to deal with non-insulin dependent diabetes or high blood pressure or depression or asthma. I see the management much the same. And so we'd be talking about the condition, we'd be talking about the profound importance of good night's sleep, good nutrition, reducing stress as much as possible, and we'd be talking about the absolute profound importance of a graduated exercise program, finding a safe entry point for that person to exercise and take them on a journey that exceeds their expectations, that they look back and say, I can't believe what I'm doing now. And also introducing a lot of chaos in that rehabilitation so that they have got, they're doing things that are not, really structured in terms of movement. They're doing chaotic movements that would happen in the real world for the shoulder. And of course, if need be, that all of those conditions can be supplemented with medicine if required. But the emphasis is, I'm not fixing you. I can't fix anybody. I don't fix people. I've got a bit of knowledge, some skills. I can really work together with you in the beginning, but at some point you're going to have to self-manage this problem forever, really. It's the same with diabetes. You can't get your blood sugars under control and then pop back to Dunkin' Donuts or Krispy Kremes or KFC or whatever it is to, because your diabetes is under control. It has to be now a lifetime in self-management until someone gets a Nobel Prize for curing diabetes. And so for me, it would be the same for the rotator cuff. And I know it's a long answer to what seems to be a simple question, but it has to be empowering the patient. I'm a coach, I'm not a fixer. I'm going to empower the patient to self-manage. We're going to find a safe entry point for their rehabilitation. It would be the same principles for me, whether it was an Olympic athlete or me turning up in my clinic or a very elderly person turning up. It would be finding a safe entry point. I would probably use symptom modification on day one, but then move into something that I would call, which I've learned from other people, the second slice of my 100-stage rehabilitation would be heavy, slow resistance for most people, which is an eccentric program, getting the patient to, in the doing an eccentric contraction in the direction of the most painful movement. So if external rotation was most painful, have the arm supported, the heaviest weight a patient can lower slowly with a metronome to distract them, and that might be just the weight of the arm. And that would be my second stage of rehabilitation for most people, and then look at all the functions of the shoulder. And it's really naive of us to think that an open chain external rotation program, tuck your elbow into your side and take this lovely piece of TheraBand, that's a wonderful exercise for a penguin with a damaged flipper, or it's a great exercise for someone with a deodorant problem that you don't want them to lift their arm, but it is not how we function. Nobody does this during the day. We're all over the place. And we're open chain, closed chain, older people get up from chairs, pull themselves upstairs, closed doors, open doors. Not at the moment, no one's traveling, but prior to the pandemic and maybe after the pandemic, everybody, whether it's a 60-year-old, 70-year-old, if they're going on a plane, is going to have to lift up 10 kilos from the floor and put it into the overhead bin of the luggage compartment of the plane. So as physical therapists, if we're not getting the patient back to that level of function, we're just concentrating on this sort of stuff, we are not thinking of our patient's needs. So we have to take our patient through all the functions of the shoulder, the pushing, the pulling, the carrying, the throwing, because everybody's going to, like I said, throw a ball to their grandchild or whatever it might be to the level they need. We also have to have a lot of chaotic rehabilitation, so the person has a lot of confidence that something's going to happen quickly at their functional level, that they can cope with that. So there's a need to be a lot of chaos. We've got to exceed our patients' expectations. They've got to look back and say, I can't believe what I'm doing now. And that's my philosophy with everybody who comes in, whether it's after surgery, whether it's after trauma, whether it's non-traumatic, it would be whether it's a young person or an old person, elite athlete, non-elite athlete, it would be always the same process, but just tailoring it to that person.
So then how do you go from this position or heavy slow resistance from here to chaos, throwing if I'm an overhead athlete, lifting the suitcase up into the overhead bin in the plane or on the train? How do you progress that? What are your guiding factors? Are you guided by pain? Can we have pain? Is it like, Achilles tendinopathy where some pain's okay? How do we get from simple here to throwing and everything else?
Okay, so for me, the only time I try not to exercise in pain, the only time I'm concerned not to increase symptoms is the very first slice of the rehabilitation, the symptom modification. So that 2 or 3 minutes of experimentation, as I've said, is to try and mess with the brain, to see if the patient has learnt, their brain has learnt that lifting their hand up is always going to be painful. So great people like Louis Gifford, if people have not heard of Louis Gifford, look him up on Google, read his books. So people like Louis Gifford, great clinicians who unfortunately are no longer with us, are saying things like nerves that fire together, wire together. So if someone is always lifting up their arm and they're always expecting pain, then it doesn't matter, they're always going to expect pain when you go through an assessment. So for me, the advantage of something like the symptom modification procedure is to try and stop that wiring, to see if I can, for the person to say, oh my gosh, I can actually lift my arm and it's not so painful.
We've just lost your audio.
Have you still lost it?
It's back now. Sorry, you were mid-flow. Sorry to interrupt you.
I don't even know where I was.
We're talking about brain wiring and breaking that cycle between expecting that it's going to hurt.
I'm sorry, my internet's not as good as it should be. I apologise. So the idea for me, the first slice of the rehab is to try and get the patient's brain to say, okay, this movement's not so painful, if I can. Sometimes it's spectacular failure. Then I would do heavy slow resistance, and then I don't really care about, and heavy slow resistance is often painful as well, but the next bit of the rehab, I don't care if the patient, sounds very callous, I don't care if the patient's experiencing pain. As long as it's tolerable for them. I think the greater, one of the things I'll say clinically is, following my assessment, you cannot damage your shoulder. If there's, if there's no sinister pathology to worry about, how can anybody damage their shoulder if they're doing a graduated rehabilitation program? So I'll say the great news for you is you can't damage your shoulder by moving it, exercising it. The only damage you can actually cause yourself is by not exercising. That's where the real damage will come from. I might package it in a nicer way than that, but that will be the message to the patient. But what we need to do is to find a level of exercise that's tolerable. It's absolutely fine to exercise in pain. In fact, we've got a couple of systematic reviews that suggest exercising in pain might get you to your goals a little bit faster. There's no long-term evidence that exercising in pain makes any long-term difference as far as I'm aware. But the advantage of talking about pain with patients is you can tell a patient it's a horrible sensation. Nobody wants to feel it. Sometimes we might have to, but the good news is the pain does not mean you're causing damage. The damage that you can cause is by not moving, not exercising your shoulder. As physios, as physical therapists, we've got to be really brave, because if we're not brave, if we're frightened, our patients are going to be petrified. And there's very little harm we can do if we find a safe entry point to rehabilitation and we move gradually, carefully with our patients, thinking about all the functions. So to answer another part of your question is, I'll probably have 20 or 30 levels of throwing, lifting, carrying, pushing, and I will try and take a patient, a person with shoulder pain, as far on that list or as far on that list as possible. For some patients, it might be only to level 2. For some patients, I have to be creative and go past level 20. But I've got 5 different Excel spreadsheets with different functional problems, different functional levels of activity that take a patient from just gently lifting their arm, maybe with symptom modification, but then starting to do it with a small weight, and then starting to pick up from the floor, and then faster, and gradually progressing in pain, as long as there's no increase in pain tonight and no increase in pain tomorrow. Those are my only provisos.
Great, thanks for sharing those clinical tips, Jeremy. And I think quite a few people in our community have been wondering about whether the exercise program should be eccentrics alone, or is it okay to bring in, say, isometric exercises? Where do closed kinetic chain exercises fit open kinetic chain exercises? Could you comment briefly on the different exercise modes and different types of exercises? It sounds like you've got a very broad spectrum and you're looking at addressing most, if not all, of those things.
Yeah, I think it would be naive to say I only give eccentric exercises. Heavy slow resistance is a really heavy eccentric exercise for that person at that point in time. But the rest of the program is open chain, closed chain, whole kinetic chain, if you want to call it that term, functional exercises. You might have a pushing program that starts with wall push-ups, going to tabletop push-ups, to knee push-ups, to full push-ups, to push-ups, lifting weights and looking at the weight, so you're strengthening the neck as well. So it's and slowly lowering that weight and then doing it. So I'd have a whole series of pushing exercises, a whole series of throwing exercises, trying to make everything a challenge. So it wouldn't be just throwing, it would be throwing maybe underarm tennis balls into a waste paper, a trash, into a container, in order to, how many tennis balls can you get out of 5 into that container, throwing at targets, and then making it more and more of a challenge to the individual, because I think humans need a challenge. This is mind-numbingly boring, but if we can give a challenge to the person and they can say, I can't believe I'm doing that, I can't believe, I'll often ask an 80-year-old, 70-year-old, when's the last time you did a push-up? And they'll look at me like I am crazy. They'll say, never, 50 years ago. And I'll ask them to go to the wall and do a wall push-up. Now, I know they can do it because they just got out of the chair, which is more weight than doing the wall push-up. But they look at you like they're an Olympic athlete. You know, they can't. And so just sometimes giving the confidence, and I think I've meandered off again, which I tend to do, but yeah, but so it's everything. It's not just, it can't just be an eccentric program. It's not how we function as humans. We use our whole bodies. We bend, we lift, we carry, we twist, we do everything. That's got to be part of the confidence we can give our patients that they can self-manage. And it's good for their heart, their lungs, their blood pressure, their minds as well.
Yeah, and I think the other thing to think about are the different ways in which we can modify load. So it might be about changing frequency or intensity or duration, and thinking about what is going to be most appropriate for that patient or the athlete or the person that you're working with at that time, and where you need to get them, or where they're headed and how you can help them on that road. Let's talk a little bit about manual therapy, because you've touched on manual therapy a few minutes ago. How does manual therapy fit into an evidence-based shoulder rehabilitation program?
Okay, another great question. So in the early part of my career, I tried to do every course that I could to become my goal was to be the very best fixer I could be. I did every weekend course that I could. I was borrowing money from my parents, my sisters, to do courses, because I really had this goal. But I thought the more I could fix people, the better health professional person I could be. And certainly when, Friday would come around and you'd go to the pub with your colleagues, and they were telling stories about how they identified that C3 was a bit stiff and they pushed on it, and this person had miraculous recovery after 20 years of never having symptoms. I wanted to be that person, and I was fortunate enough to get into the manipulative therapy course with Jeff Maitland, who was teaching still at those times, and what an inspirational man he was, and courses with Brian Mulligan, absolutely inspirational people who, so much respect for them that they were brave enough to say, I've got a different way of moving forwards, and they gave our profession a lot of focus, I guess. But I think if you look at the history of our profession, I think maybe we followed that passive direction from about the 1950s onwards, maybe too much, and we lost sight of some other important things that we could offer. And for a big part of my career, the fixing part of my career, I guess I was spending a lot of time treating problems that probably didn't exist or don't exist, with techniques that probably don't do what they're designed to do. And I've had an absolutely huge privilege in the last 15 or so, maybe longer years, of going to different countries and seeing how different physios work. And what for a long time I was thinking, if I was, in Japan and doing a Maitland course, and I couldn't understand what the teacher was saying to me, and I was just copying the techniques, and then next week I was in Iceland doing a trigger point course, and I couldn't understand what the teacher was saying to me, and I was just doing the techniques. And then the next week I was in China and I did an acupressure course, and I couldn't understand what the teacher was saying to me, and I was just doing the techniques. I wonder if I was having my reflective movement after those 3 weeks. And I wonder if I'd be saying to myself, you know what, I think I've done the same course 3 weeks in a row. Because I think what every culture has found is that there is some value to therapeutic touch. And I think what we've done is we've packaged it in a way to explain it to ourselves, that in one country we're deactivating blocked meridians, in another country we're deactivating trigger points, somewhere else we're mobilizing stiff joints. But I think at the end of the day, if we look at the research, whether we're in physical therapists, chiropractors, osteopaths, it seems to scream at us that we can't identify spinal levels, we can't move joints. And that's great news. Who wants to be able to do a PA on the central part of the spine to cause a PA movement of the vertebral column? No one would want to put that sort of depth pressure on the spinal cord. But I think what we've done is we've packaged therapeutic touch in a way that we make sense to ourselves, and we can explain it to patients, which I actually think is harmful for our profession and for the patients. There is some research, and we published just recently in the journal, JOSPT, and others have published elsewhere, that there is some advantage to manual therapy, but it has to be a short amount of manual therapy. It has to be in the beginning of the treatment, and it must be with exercise. And by itself, long term, I think we are offering inappropriate treatments. We are offering disservice to the communities that we're serving clinically. We've got to move away from ineffective treatments with inappropriate explanations for those techniques. We are, in my opinion, and I'm sure many people are disagreeing at the moment and throwing tomatoes at the screen. I think we have to look at the research, and we have to move away from maybe some beliefs we have held, but may no longer be true. So a little bit together with exercise. I think the COVID experience has shown us, for those doing telehealth, that it's maybe not as important as we may have thought it was.
So let's pick up a little bit on the exercise part and do a bit of troubleshooting in our last roughly 10 minutes. What do you do if someone's not responding to an exercise therapy program? Because I'm sure that there are people out there in the community who will be screaming at us saying, I'm doing all these exercises, I'm trying my best, and the person's still saying, I've got the same problem. So what sort of tips can you share with our community, Jeremy?
Okay, that's a fabulous question. So I don't think I have better results than any other physio in the world. I don't think any physio has necessarily better results than another physio. I think, we're all going to have patients that we get better responses from and poorer responses from. Like I said earlier, I don't think I fix people. I've moved away from that. It's created a lot less stress in my day. I don't go to work fixing people. I go to work trying to coach, trying to empower, trying to get people to self-manage the best they can. It's always an unknown for me. Am I going to, most often, when you're talking to a patient, asking them to tell the story, their biggest problem is often, I need to get rid of my pain. They've had multiple injections, they've had surgery, maybe multiple surgeries. They've had this technique, this taping, this acupressure, this mobilization. Their whole goal is to get rid of the pain. And of course, no one wants to walk around with pain. Most people don't want to walk around with pain or have reduced experience of pain. But it's not something that we can always do. We don't have the skills, the techniques, the drugs, the injections, the exercises, the operations to do that for most people. And we're selling people myths if we tell them that we can do that by correcting this imbalance or this posture. What I think I would try and do with somebody who has had a lot of previous therapy, which is often a patient group I see, is talk to them about, what have people told them? What do they think they need help? What's their goal? And I'll often be honest, so I'm not always able to reduce the experience of pain, but if you're happy to work together, let's see if we can get you to do more valued activities. What's valuable to you? Let's see if we can achieve that, and maybe make that the focus more than the reduction of pain. And if pain is reducible as part of that journey, and sometimes it does change over time, then that's a bonus, but it's not usually my main focus.
And so
I don't know if that answers your question, but that's as good as I can get, probably.
And what would be the time frame within which you're looking for a response? How are you sort of educating people and sharing with people that you speak to about what to expect? How many visits are you seeing a patient for? How does the day-to-day sort of work?
Okay, fabulous question. So the research at the moment would probably suggest you need about 12 weeks minimum of rehabilitation. Now, a lot of health services don't allow that. In my head, it's sort of like saying, well, here's the research evidence for antibiotics for pneumonia. You need 7 days, 3 times a day, but we're only going to give you 2 days worth. The people who sometimes provide the infrastructure for health they need to be listening to the clinicians, the researchers, and saying, okay, we need 12 weeks. How are we going to organize that? You tell us what you need, we'll sort out the system, but it's often done the other way. So 12 weeks on average. It could be a couple of times initially for the first few weeks. Maybe you want to use some manual therapy. I would try not to use manual therapy. I don't think it's important. I think if a patient says, when you ask a patient what's going to help you, they're going to say, if they say, oh, I had manual therapy last year, it was so good, I need it now. I would never, it would be arrogant. It would be so rude and arrogant to say, oh no, that's not something we do. I'm going to say to the patient, wonderful that you know that something has helped you. Let's absolutely build that into the program. But this is the second or third time you've come back. Let's try and find a way to reduce the need for you to come back. Let's find a way to self-manage. I really hate it when physios say, oh, we don't do manual therapy, to the patient who says, that's the only thing I know will help me. It's not the patient's fault that they think manual therapy is going to work. It's because we've given it to them previously. But I would tell the patient it's a 12-week program. It won't be a linear improvement. It will be a bit up and down. I would draw a graph with the patient. I would never allow the line of improvement to touch the x-axis. I'll give this to the patient to take away, because very often we can't always reduce their symptoms to nothing. I would say that this has to go for at least a year, 2 years. In fact, it has to go to forever to help you maintain your strength. You could use that graph as a way of talking about how lifestyle, the patient says they're a smoker. You could talk about how that could, I don't want this to sound like a lecture to the patient, but how if we really want to make the very best we can, you can find it, in your time to reduce smoking or stop. There's so many ways to support you doing that today. Of course, it's your decision. I don't want to influence you, but continuing those lifestyle changes may not allow you to get the best outcome you want. About 12 weeks, about once a week. Could be a bit longer, could be a bit shorter. If the patient's getting worse and worse, I've made a mistake, it's a different condition. I need someone cleverer than me to see the patient.
Now, in our last 2 minutes, what I'd like to get you to do is to imagine you're at the end of your workday, you're sitting back, you're taking a breath, you might have a beer or a glass of whatever you like on the table, vodka. What do you see when you start to look over the horizon? What's in the future for musculoskeletal rehabilitation?
Okay, great philosophical question to finish with in a minute. So I actually think this could be our golden time. I actually think this could be the golden time for our profession. It could also potentially be the end of our profession as well. I think, and I think the pandemic is actually a really great opportunity for us. It's been horrible, and lives are lost, and lives have been shattered, and businesses have collapsed, and the world doesn't know where it's going to come out. But the skies are bluer in London. The birds are singing louder in London. We've shown ourselves with telehealth that we can maybe manage people in ways that we didn't think we could manage them. We don't have to do a lot of manual therapy, acupressure taping on patients, modalities. And a lot of patients, this is a great time to do an experiment of 500,000 physios, many millions of patients. How do they improve over this period? And I think if we look at the research, we go back to a time maybe pre all the passive interventions. We use passive interventions less. We move away from fixing people. We move to a way of getting people more physically active, which is going to be ultimately great for all our health services in terms of reducing diabetes, reducing heart disease, improving respiratory fitness. Most of us have learnt new skills during this pandemic. let's incorporate that, be more holistic. So I actually think this could be a golden time, but my worry is that we might go back and revert.
So I think it's on all of us to make sure that this is a positive thing and a positive step forward rather than something that we end up going backwards from. Jeremy, a great place for us to finish our JOSPT Asks live stream for today. Thank you so much for joining us.
Thank you very much for having me. I hope it's been useful. It's been great talking to you, Claire.